So what are the steps in pelvic fracture urethral reconstruction? Number 1 is mobilization of the bulbar urethra. Okay. So our principle is going up to the obliterative segment, number 1. Number 2, excising all the fibrous tissue. That is very, very important. Number 3, having a tension-free end-to-end anastomosis of the proximal and distal severed ends. Okay. Anybody wants to wash up, they can wash up. Always welcome. So again, the principle remains same, that you be in the midline till you see the bulbous spongiosum muscle. Okay. This is a perineal, superficial perineal muscle. मिलकर आया कि नहीं है? हाँ?
वैसे काम 7.5 नंबर क्लोज है सर राउंड है सर
अनिल किधर है अनिल? So there we find the muscle. Avoid a lot of crowding into the operation theatre, please. So this is the nail cath. Number 14. We insert the nail cath, okay, into the urethra to find out what is the length of the urethra we are dealing with. So if you put your finger here and take out the nail cath, we find that is a good length of the penile and bulbar urethra, and that is a plus point. Okay. Come on. Okay, fine. So now, as I told you, there is this bulbospongiosum muscle, which we can see. Okay. And once you see the muscle, you go laterally. So the blood vessels are retracted laterally. And so there you go. No bleeding happens if you are in the right plane. The Gallodes fascia or the muscle needs to be preserved properly so that the muscle does not get compromised. It's an important muscle for sexual function. And so when we call this operation as posterior anastomotic urethroplasty, why it is called posterior? Because you are supposed to go posterior. And if you do not, the first mistake what most of the urologists do is they do not go posterior adequately. Okay, so you have to go adequately posterior to have a good success in this particular surgery. So we have our first retractor, the retractor coming in the first blade. Okay, this is another. Okay. A motor scissor. So this is a pediatric one. This is a small child, no? So, but the problem what happens is the bigger ring, no, does not fit in here. So most of the problems start there then. So it is better to use a pediatric one here. Sure, done. So let us now open the bulbospongiosum muscle. So midline cut. So usually in reconstructive surgery, we do not require to dig the scissor in and open it like what most of the general surgeons do. So we need to work superficially and go deeper rather than working the opposite way. So we don't need to do this. It is seldom required to do that part. So you need to look at the raphe properly so that you cut right and you go to the right plane and at one level rather than going at multiple levels. So can everybody see this raphe here? It's very clearly seen actually. You cannot mistake that. So we don't get deeper. So once you are there, you go laterally. So the first step is in progress where you mobilize the bulbar urethra. So this is accessing the bulbar urethra. The next step is so important part here is do not denude the fascia on the urethra also. The urethral fascia is very important. And the urethral fascia, Master. You should not be denuding the whole urethra of its fascia, okay? So that's very important that because you have to mobilize this urethra circumferentially. And if you denude its of its fascia, it's going to get weak. So never try to. अली सर है क्या सर सब दिख रहा है ठीक से everybody is able to see it sorry bulbar urethral cause is only one scissor bulbar urethral ischemia is multiple mobilizations when you mobilize the urethra multiple times see how is the urethral blood supply so let us go to the point of very good question here so urethral blood supply comes from two sources proximally antegradally and retrogradely right antegradely the supply comes from the penile arteries right and proximally it comes from the cavernosal arteries am I right so and there are perforators which come from the corpora into the spongiosa okay so the moment you mobilize this urethra multiple times you are going to obliterate that supply coming from the perforators like recurrent zero surgeries so what is the cause of bulbar necrosis number one stretching of the urethra so once you as I told you if you transect the urethra too distally okay and you lose length then you try to stretch the urethra and anastomose it proximally that is the most common cause of bulbar urethral necrosis that you stretch the urethra beyond its capacity and then you find that the urethra is rendered but every time you mobilize the from its bed it's going to lose some part of its blood supply okay have I answered a question so never have a anastomosis which is with tension infant fitting tube लगेगा 5 number या 6 number okay so now this is the how long you need to go you need to go up to the complete bulbar urethra where is the bulbar urethra up to bulbar urethra is up to the petroscrotal junction so as I told you never denude the urethra of its fascia so the urethra should look pale and not dark purple If it is looking dark purple, probably you have denuded the urethra too much of its fascia. Okay. So it should never look too dark purple. Okay. So now let us go around. You need to be very patient in doing this so that you don't create any harm. Triangular ligament, everybody. Can everybody look at the triangular ligament? Very clearly seen on this side and this side also. If you see, my scissor is a pointed steel scissor, tympanoplasty scissor, which helps dissection. Infant feeding tube. So we have gone adequately proximally. Okay, that was I was telling you. If you only start the dissection from here, you do not go beyond this up to the perineal body, your surgery is never going to progress. So, my dear friends, it's very important for you to realize that if you want to do a good anastomotic urethroplasty, you need to go adequately posterior. Okay, section. Sorry. DRE for? No, we will do it. If you think that you are very close to the rectum, you should never hesitate in putting one finger into the rectum and proceeding further. Okay, but here I know that I am good. So what happens is in redo surgeries, when there are a lot of fibrosis here, which makes your differentiation of tissues difficult, then 100% you need to. So everybody can see the perineal body. I am disconnecting the urethra from the perineal body. Okay, now back work. So we'll hold the proximal bulbar urethra with the, and now we need to, what I tell you is go posterior. Okay. See, this is going posterior. This, can everybody see the perineal body? Very easily you can see the perineal body. And when you cut, you have to cut with just a tip of your scissors so that you do not cut the wrong things. So my assistant, कौन है? Doctor Samit. So Samit is holding the urethra and we are now disconnecting it from the perineal body. Okay. So this is the right plane. And if you see, my scissor is completely parallel to the ground. If your scissor is parallel to the ground, very less chance that you might injure rectum. Okay. Fine. Now let us infant feeding tube. So we have lifted the bulbar urethra from the perineal body. Okay. So that is what exactly is now what we call as bulbar urethral mobilization. Okay. So, suction karo. So we have hooked the urethra. Hold. Now we are going to mobilize the urethra. So number one step is bulbar urethral mobilization. Number two is urethral transection. Now somehow this step has never been mentioned, but I have introduced this step of transection because you have to understand that this is the rate limiting step of your surgery where you transect the urethra. So that has to be included into the step. And then is crural separation. Then required rerouting, inferior pubectomy, and then complete pubectomy and abdominoperineal repair with omental wrap. So these are the steps of progressive anastomotic urethroplasty. Yes, go ahead. Tell me. If you're not, now what does your steps depend on? There are so many steps. Your steps are here to access the proximal urethra. If you are not able to access the proximal urethra, you go one step beyond. You start extending your steps. If I am able to find the proximal urethra only by bulbar urethral mobilization, I do not go further, right? So your quest is to find the proximal end. A panimar, so see what I'm doing, slowly trying to get the bulbar urethra off so that I reach the proximal blind end. See, if you are able to do this step properly, most of your surgery is going to be easy. And here, most of us falter in this part because this is going to bleed. You have to understand. See, can you see my urethra is getting free? I don't have to cut. I'm just separating the muscle so that my okay suction, niche section karo. So can everybody see that the bulbar artery here? So I've reached. Suck properly. इसको बंद करो. Suck properly. Suck. A suction. Suck. So never get scared of the bulbar artery. It is always going to be there. That marks the proximal dissection of our surgery. Okay, that means you have got adequately proximally. Okay. If you again see, I am going beyond. Okay, so let us go a bit. Suck. Okay, so you are separated. Nursi, पकड़ना इसको ऊपर. Hold this nursi. So now, suck where am I operating? So this is the mobilization of the bulbar urethra up to the penoscrotal junction. We got much beyond. Since our gap is not too much, we can refrain from mobilizing too much of the. Since I told you that your bulbar urethral necrosis is going to depend on how much urethra you're going to tamper. See why I'm using the word tamper, because you're actually tampering. What you're doing is you are trying to lift up the urethra from its normal attachment, just job easier. So there is what is called as tampering of the urethra. So you can avoid more tampering if you feel that your anastomosis is going to come easily, until you feel that. So most of the times I don't even go up to the penoscrotal junction in traumatic cases if I feel that my anastomosis is not going to be very tough. So see, when you're cutting these strands, what you're cutting actually is the blood supply from the corpora to the urethra, which is very crucial because that is a salvage blood supply to the urethra. Okay. So once I've done the complete mobilization, if you see, I've lifted the urethra from its base, the rectum is just closed there. Okay, I'm going to just separate the muscles from here. Okay, now I'm going to use a dilator, male dilator, steel ka, yellow, jelly. Now I'm going to use a dilator and I'm going to see how far we have gone. So if you see, we have gone almost up to the obliterated part. Okay, so now I can transect the urethra, but suction, good suction. Now the other bulbar urethra artery is going to come here. So the more proximal if you go in this dissection, section के लिए काम कर रहा है. The more proximal you can go, can you see the bulbar artery? This is the patient's left-sided bulbar artery. Suck. Suck at the source. You don't have to touch the suction. Suction को touch नहीं करना है कभी. When you suck, you have to suck like this. Can you see that? Hold this. When you suck, you don't have to kiss the suction. So you have to just be on the side. So when you're sucking, you don't have to put the suction completely end on to the tissue. You have to leave some air so that the air will suck here. The moment you put the suction like this, it is going to get blocked. So you have to always suck on sideways. Okay. So can everybody see the urethra has been mobilized? And now we have gone so proximally that now we can transect it anywhere because we have reached that place. Successor. So see, I'm just at the urethral level. Can you see the bulbar artery here? Is the bulbar part of the bulbar artery on the urethral side? Okay. So now I'm going to transect this urethra at this level because this is our final level. See how deep I have gone. Can everybody see that? So never be in a rush. Never be in a rush or hurry to transect. Go as proximal as possible because the more proximal you're going to go, the more you're going to win. Okay. So one more time, the bulbar artery has been encountered. ऐसा करना ऊपर ऊपर यहाँ पर ऊपर ऊपर और ऊपर नहीं दिख रहा है नरसी चलो डन okay so that's it that's checking the urethra. Can everybody see? Now luckily this is the easy case with less fibrous tissue. Okay, so this is a friendly case for us. Okay, so that's how we transect. Okay, so that's where we have transected the urethra. So this Babcock is an important marker. Take out that. Take it out. So this is important marker of 6 o'clock position of the urethra. So you apply the Babcock like this now. Dilator. Okay, we just pack this wound here. We don't need to do anything. Okay, fine. Dilator kahan gaya? Jelly. Okay, so we start the dilator here. Okay, so we very gently pass the dilator into the. Can you see this part? This is the obliterated part. Okay, almost obliterated part. So now, scissor. So we are going to spatulate the urethra. Can you see that? Okay, now important part here. Whenever you spatulate this urethra now, when you see it so well, you need to understand that this urethra there might be some gray area remaining in this urethra. Luckily, there is no gray area, but most of the times you will find that half of this part is going to be fibrous. So you should never include the distal part of this urethra into the anastomosis. Always pair some part here and use this part for the anastomosis. Because most of the time this might be fibrous and this might create problems for you. Okay. So never use, can you see this fibrous part? So this is the tissue which is completely fibrous. So never use this part for your anastomosis. So we are going to just trim off the fibrous part. Now, when you say fibrous, you have to feel it. You should not go on the site of it. You should feel whether there is really a fibrous tissue or feel. If you feel it is very hard and stiff, please excise it. Otherwise, you can just keep it back. You don't have to be aggressive in doing that excision. Your orientation is very important. Straight like this. Okay. So this is the adequate spatulation what we have done. Okay. So we are going to use this part of the urethra for anastomosis, not this part. Okay. So if you take sutures here, you are going to 100% fail. If you're going to take this as the human, you're going to pass your exam. Okay. So let us excise the obliterative part. There you go. Now we just park this urethra. And now we go proximally. Okay. So now our step of crural separation. Now, crural separation, in this case, it is easier because there is some amount of erection. So you take a knife, specifically a blunt knife, not a very sharp knife. And can you see the very easily? Can you see? So just take a nick on the raphe. That's it. This nick, the first nick decides whether you're going to go on the right plane or no. Okay. So the moment you take the first nick, which is right, you are invariably going to enter without any force into the proximal urethra. Okay. Into the corpus. So this very lightly, you don't have to apply any pressure at all. Can you see that? Everybody is able to appreciate? So I'm not cutting actually. I'm just cutting to thin, flimsy bands which actually join both the corpora. Now, since he's a pediatric age, the androgenic effect has still not come. It is easier. Happens in elderly people that this tissue is quite tough and it might not be very easy to do this step. Narsi, pakad. Okay, so now I'm going to go for so pull karna dono side pe. So both of them are pulling on this. So be very careful not to go very deeper here because there are going to be the vein on the structure. Very good, Narsi, very good. Very good, very good. Can everybody see that? अली भाई ज्यादा ऊपर से रिकॉर्डिंग मत करना क्योंकि दिखता नहीं कुछ भी. हाँ be at my level. Don't suck. These are the interconnecting branches. Okay, fine. Now open this up slowly. Okay, let us now do some hemostasis. एक गॉज लेके रखना please. Let us do some hemostasis here. Now the bulbar artery is already under control. What is there? The vein. Be very gentle here, especially in small children, because you might damage if you're not careful. Okay, fine. This is a bit notorious. Okay, सब करो नीचे. पानी देना. Okay, now let us go to the proximal part. Most of the times, if you've done the dissection proximally very well, you will find the proximal part very easily. You don't have to actually struggle. Okay. So next dilator देना. We'll go proximally. Jelly. डालना उसके अंदर से मुझे. किसी कहाँ है? नहीं, force नहीं करना. So when you're going suprapubically, never force. Be very gentle. So as I told you, this is a good point that we are able to. इसको निकाल दो. इसको नहीं चाहिए. निकाल दो. Can everybody see the impulse? So now important part is we need to cut at the right impulse, okay? Because impulse can come from multiple points. It can come from the bladder, it can come from the urethra, it can come from the mid-prostatic urethra, okay? If you cut at mid-prostatic urethra, your anastomosis is going to be wrong. If you cut the impulse on the bladder, you're going to do a pseudo-anastomosis. So your thing has to be as distal as possible. So not here, it has to be here. Can you see that? So knife. So I'm going to always touch and cut. Suction. So don't be in a hurry to cut. Be very careful when you're cutting. Very light drop. Always feel the dilated tip and then cut. That's how you go. So we can see the amount of fibrous tissue here. Can you see that? So that's how you go there. Okay. Just slowly suck here. Suck करना. Okay, now let us start working. What is the work now? To isolate the proximal mobile urethra. Important concept. Ali bhai, ye dikhana please. So this is the urethra. Can you see? This is the urethra, okay? After pelvic fracture, urethral disruption happens. So both these ends are separated, okay? Fibrous tissue comes in between. This is the distal urethra. This is the proximal urethra, which is fixed. What you do is you release bulbar urethral mobilization. This urethra is free. So this is this urethra, which is free. Now it needs to get stuck here. Important thing is that if you take out the fibrous tissue, and if this urethra is still fixed, and this urethra anastomotic to the fixed urethra, during erection or any manipulation, it is going to snap out. Repair fails. Okay. On the other hand, you mobilize this part, you mobilize this also to some extent, and then you anastomose, your anastomosis becomes flexible. The principle is mobilization of distal urethra, proximal, then the anastomosis, so that the anastomosis is free to move because penis is a erectile organ. The moment it gets erect, if this is fixed, it is going to fail. Okay? Truth for sir. सबको समझ में है? What am I telling? So now let us start excising the fibrous tissue is excision. Okay, so I'm going to just start excising the fibrous tissue. Can you see that? Now, where is the fibrous tissue? It is not at the 7 to 5 o'clock. It is usually on the upper side. So this is the fibrous tissue which we need to excise. Not be very aggressive and doing the surgery. So you have to be very gentle and very thoughtful before you cut anything. Because it might damage and create more harm. So that's how we take out small bits of fibrous tissue, okay, which are engulfing the urethra. Can you see this fibrous tissue? It is engulfing the urethra to get fixed. It is not soft. It is tough to feel. To watch, it is tough. When you actually do this, you will find that this is tough. And sometimes you have to. Whatever the white you need to actually, when you start doing a lot of cases, then you start understanding the anatomy of this problem. And then automatically you'll find which you'll be able to recognize. So that's what I always say, that doing this case, you need to learn, have some experience, and then start doing it, because a failed pelvic fracture is the worst scenario for any reconstructive urologist. And we still don't have a very amicable solution for that problem which we are talking about, called as bulbar urethral necrosis. Still no amicable solution. Recently, I had a patient from Pakistan who was operated 5 times for a simple pelvic fracture, and he had all sorts of repair for bulbar necrosis, including forearm flap. Everything has failed. So we invited Dr. Rajesh Rajendran, who is from Trichy, and he did an entire urethroplasty. So we created an ileal flap for him to bridge the whole gap. Patient is now fine. He's gone back to Pakistan and he's happy. The point is that there are very few options which remain after you tamper the urethra. So this is all the fibrous tissue which I'm excising. And the moment you start doing a lot of cases, you will understand that anatomy starts. The anatomy of pelvic fracture is difficult to understand. So now, still there is a lot of, I see the urethra is still fixed. I'm not able to still mobilize. That means we have to still go a bit more proximal. Okay, so I'm going to go a bit more proximal by excising this part. And I'm going to excise some tissue, which I think is engulfing. No, for this, in trauma, there is no role of methylene. Most of the fibrosis, the urethra will take up the fibrous tissue. Here, delineation of anatomy is very, very important. The moment you put methylene blue, everything is going to get stained and you're going to have a big problem. So no methylene blue is used for this purpose. So can you see the fibrous tissue? Now this is perfect fibrous tissue. There is no argument over this. Is there? Can you see that? नर्सी तरफ सेक्शन बहुत ज्यादा, बीच में थोड़ा शक्कर बाद में हो जाए. Sorry, new surgeon, what do you say? The new surgeon need, I don't know whether everybody will agree, you should not be new to this surgery. That is, you should have somebody who can, right? If you're going at which is dangerous, you will not like to go alone, right? Somebody's help. So I would urge everybody to call somebody who knows this and do the surgery along with and learn the thing first, understand the anatomy, and then start doing the surgery. Because once you do it, now this is a young man. If he is rendered necrotic in the bulbar urethra, his whole youth is spoiled. Like that Pakistani patient has his trauma when he was the age of 8 years. Today he is 22. Can you imagine the plight? He's been on a cassette for 12 years. See, this is fibrous tissue. There is no contention. Okay. So now we can put this bigger forceps. See, I told you in the previous surgery, if you're able to put your forceps without suction, that means you're doing a good job. Okay, that means you're really, or if you have to struggle to find out this, that means you're not right. So there's still amount of fibrous tissue which is there on this side. This is pretty okay. We are going to further open it. Okay, and now we can see some healthy. Can you see this? Some healthy mucosa. Suction. Okay. I'm excising the fibrous tissue around the urethra. Okay, so that the urethra becomes free. And never go beyond the veru. So that is very important part. What happens if you go beyond the veru? The veru is still further inside. Can you see the veru? It is far inside. So I'm going to again take this tissue and start excising. That's what I'm telling you. Sphincter is at veru level, no? I'm not still reached the veru level. So you should not be going. You should not be going proximal to the veru. You should always remain distal to the veru. Because the chances of incontinence will always increase if you go distal to the veru. Sorry? Oh, yeah, no, here also the same thing, no? At the level of the veru, there is a sphincter, right? So you should not go at the level of the veru also. So can you see all the fibrous tissue being excised? Yeah. Can you see the urethra now shaping up? Okay, ना analysis को ऐसे. सुमित इसको दबा के रखना नीचे. Force को दबा के रखना. Just do some hemostasis here. So now if you see anatomy clearly here, see. Now this is the urethra. Can you see this? This is the urethra. And the tissue above it is the fibrous tissue. Can you see that? Now the moment I will excise this, you will find that most of my urethra will become clear. Okay. See, now this is the which needs to get out. Can everybody see the fibrous tissue being excised? See, yes, yellowish tissue is all fibrous tissue. You see that? It is the proper circular orientation or semicircular orientation all around the urethra. I'm going from one side, coming to the opposite side. Can you see that? So now your urethra is done. Can you see that? Okay. Everybody can see this? Can you see this urethra now? Perfectly mobile urethra. Okay. Slight spatulation and we are done. Okay. Very well. Healing edges of the urethra. All the sides you need to have the urethra which can be, all the edges needs to be seen. Some more excision. Till you are happy. Okay, now light which is remaining on this side, we are going to excise and then you are done. Okay. So, as I told you, putting the urethra inside, the forceps inside easily, this side, and the urethra can be. Okay, perfect. Everyone is, or anyone has anything to suggest? As I told you before, all of you, this is not a one-sided session. This is a two-sided session where I want people to interact well so that. So now, as I was telling you, now you assess whether you really want. There is some erection which is there. We are going to just puncture the corpora so that the why I'm talking about the erection, because there is going to be some tension. इसको जला लेना ऊपर. So we'll just release some urethra if you want, but we should avoid doing a lot of mobilization. I think that is good enough. Okay. Okay, fine. So there's a good urethra which is there. So where is our lumen? It's here. Okay, so how you need to orient the urethra is properly, whether it goes easily inside. Okay. Sure, pakdo. So this is our distal urethra, and this is our proximal. So let us thoda sa. Okay, erection is better now. We don't need to puncture. Let us start doing the anastomosis. Suction. 40 vicryl, please. There is a small stone there. You just come out because of the catheter. Can everybody see the veru? ये अंदर वेरू दिख रहा है. आलिफ साहब दिखाना जा रहा है. दिख रहा है. Everybody see the veru? No. Can everybody see the veru? The tip of my suction. No, not seen. अच्छा मैं हाथ निकाल देता हूँ. इसको ऊपर लेता हूँ. अभी दिख रहा है? ये देखो ये वेरू है. Okay. And the urethra is good and mobile. Okay. Now let's take the stitches. 40 vicryl. 6 sutures. Next patient ready, please. Pani. Next patient ready. So first stitch 1 o'clock. No, normal vicryl. We need a strengthening suture here. So first stitch at 1 o'clock. Hold the urethra properly. Pull it out. Outside in. Okay, outside in. Narsi. Outside in. So you take the first stitch and the second stitch inside out. This is the stitch. Okay, so we take. It's very important to take the mucosa. Okay, sometimes you can miss out on the mucosa. It should be a through and through proper stitch. So outside in and inside. Curved forceps. Curved. Cut. No, I'll tell you. This is 1 o'clock. Okay. Now 11 o'clock. Next vicryl. Pani. Okay. Okay. So now other one is 11 o'clock. Pull the urethra out. Outside in. Okay. Can everybody see it? Outside in and inside out. Pani. So you see good bleeding edge. That is a good thing. इसको ऐसे नहीं पकड़ना. इसको ऐसे straight पकड़. नहीं एक छोड़. Nice. Okay. Outside in, inside out. Okay. Good stitch. चलो curved forceps ready करके रख. Next stitch now 3 o'clock and 9 o'clock. Okay. Pani. Suction. तो अलग अलग stitch क्यों दे रहे हो? Okay. Now we turn the forceps and take the 3 o'clock. Outside in. Can everybody see 3 o'clock suture? 3 o'clock. Outside in. Inside out. So 3 o'clock stitch. Good bite. Never take a smaller bite here. So, straight. Mercy, भूल गए so. Cut. Now, 9 o'clock, Pani, section. So we have 9 o'clock. Pani Maro. Such inside. So can you see the 9 o'clock here? It's here, okay? So take the 9 o'clock, okay? Can you see 9 o'clock? Hold. इसको पकड़ना है. So you hold it properly. You take a proper 9 o'clock stitch. 9 o'clock, okay. Take it out. Outside in, straight forceps. Outside in, inside out. 9 o'clock stitch, okay? इसको straight पकड़ना. Okay. So this is 9 o'clock. Now 6 and pull it straight up. So now the last two. मोटा forceps करूंगा. Left. Right it. We don't need any fancy needle order here. It's very simple. Just go deeper here at one place and come out at, sorry, we have to first is the 5 o'clock. So what you need to do is just go and come out at 5 o'clock. It's very easy. Okay, you don't have to do anything which is very tough. It is very simple. And we just have to understand that the stitch is here not for cosmetic reasons, for functional reason. So the stitch needs to come and anchor properly. So outside in, last stitch here, as I told you, we are not going to go much distally here. Outside in, inside out, curved forceps, please. Catheter number 14, silicone, cut. So this is 5 o'clock. Pani. Sir. Now we go for the Romovac suction drain pile. Suction. Again here we go deep and you come out at suction. Wherever you want to come out. Okay, okay, so now we need to come here. So this is inside and come out at. Everybody, okay? 7 o'clock. Can everybody see 7 o'clock stitch? अरे हाँ ना बोलो ना यार. नहीं बोल रहे. Suck. It is getting. Now it is okay. Wait, मत करो इधर मुझे. So we have to go deep enough so that we do not have a compromised suture. Okay, so outside and so straight. नीचे नहीं रखना है. Outside in and again parallel to this inside. Needle थोड़ा bend हो गया. कोई दिक्कत नहीं, हो गया अपना काम. चलो, okay, curved. Okay, so 6 switches in place. Okay, upper straight up. Now your forceps needs to come from here, like divide that both all the switches and go in the midline so that switches are not getting entangled. 14 number silicon folies, please. Go more at section name number 12. Can everybody say Veru now? Now it is very clear. Huh? Switcher. So 1 o'clock, 11 o'clock, 3 o'clock, 9 o'clock, 5 o'clock, 7 o'clock. Simple. Okay. So now let us put the catheter. Is that it? Okay. Now important thing is when the switcher comes out, the person who's assisting you needs to be attentive so that the catheter does not come out at a wrong end. So straight pakadna is. Always hold it straight so that it will not get entangled. So here you come. Somebody hold this. Orientation is not right. Nice. Okay, now you got straight. Now the catheter is going to come out straight. Okay. So it is not coming out and bypassing any stitch. So now we're done. Chhod do. And now we go inside. Narsi, please inflate. Now you take out this forceps, push your catheter in. Ask us, yes, inflate, please. Very good. Thank you, Narsi. Now you go down. Okay, now you pull all the stitches. Take this out. You pull the 1 o'clock. So you pull the 1 o'clock stitch. 1 o'clock, 1 o'clock, 3 o'clock, 9 o'clock, pull it out. 7 o'clock, 5 o'clock, 7 o'clock, pull it. All pull. Okay, now you tie the stitches like you did the initial time. Okay, so first goes first. So when I'm doing this, one of my assistant is going to pull the bulbar urethra inside like this. Okay, ऐसा अंदर डाल अंदर की तरफ push किया, push it inside, and now I'm going to tie the knot. Push it inside. Today there is some problem because of the erection which is there. I don't want to do anything to this erection because it is a challenge which you need to accept that your repair needs to withstand this erection also at some point of time, right? So the moment you anastomose, as I told you, if you have mobilized the proximal urethra properly, you will never have a problem with erection also, okay? And that is the best proof to it. Because you have made the proximal urethra capable enough of moving forward, right? So the erection is not going to affect it. So this is young child, I don't want to perforate his corpora at any cost. So I'm anastomosed. I can see that proximal urethra coming down and helping me in shaking hands. It is not a one-way trade treaty, okay? It is a two-way trade treaty. So 2. Now we go for the third one. Your work is done now. So before now, what I'm going to do is this one step which nobody will teach you, that you need to, you have anastomosed the mucosa to mucosa now, right? What about that big spongiosal tissue which is there? It also needs to go down. So it has to go up to the proximal anastomosis because at some point you have disconnected the spongiosa, right? The spongiosa needs to go back to that original position. I'll show you how I take it. So before I knot the 5 and 7 o'clock stitches, first I'm going to take the stitches which are going to drag the tip of the spongiosal tissue to its original place so that it does not hang loose. Next patient ready, please. Okay, so I want it ready. I'm done. Okay, drain. So can you see this? So Babcock, stitch, sorry, suture cutting. Babcock, Vicryl, please. Hold needle is there. So now what I'm going to do is before I tie these two, I'm going to park them aside and I'm going to use this. So now everybody will appreciate that this spongiosal edge. Can you see this? And there is a residual spongiosal edge below our anastomosis. Can you see this? So we have to, at any cost, anastomose these two edges together, though. Can you see this spongiosal edge? This is spongiosa, what you see, okay? So you have to anastomose this to the spongiosal tissue. Then our vicryl. So the spongiosal tissue which is there needs to get anastomosed with the spongiosal tip. So we take this suture which will incorporate the spongiosal tissue together. Mosquito, stay. देखो one more कट करो इसको. Okay, now on this side also, can everybody see? Can everybody appreciate this? This is the spongiosal tissue which needs to get incorporated into the anastomose, so that we don't have any deficit which is remaining. So now, before I'm going to do this, I'm going to now first do the, and then from outside the spongiosal covered. Cut suture cutting. Next, hello. If you pull the sutures are tight enough. They are not loose, okay? And they're strong. Cut. Hold needle. So now we are going to do called as a spongioplasty. Okay, so we have to do this spongioplasty after we finish your repair, so that this is the blood supply of the urethra actually, you know. So it goes back to the place where your anastomosis stands. So the continuity we have established what we have discussed. Cut. Same way here also. Betadine wash to me. Cut. I'm going to now fix the urethra. Since I mobilize the urethra, it is our responsibility to fix it back. Hold up. So this was, and there is a chance that you might roll over. So you just fix this urethra where you mobilize it to the sponge, to the corpora back. Okay. So this is the stitch. So don't go very deep into the spongiosa. Just fix this urethra because the catheter will allow it to roll over, no? Because we have mobilized it, cut. So this rollover will be prevented once you take this, which is also during erection, whatever the pull happens during shifting the patient will not be transmitted to our anastomosis. So these are critical sutures which you need to take, which will prevent our anastomosis from being compromised when the phallus, which is pendulous outside, is being manipulated. Okay, done. Couple of more stitches. मुझे वाइक्रिल देना 40. Mercy. Any questions anybody has, please ask now so that everybody will benefit. Sorry. Louder, please. 6 o'clock and you can take switches from 1 to 12 o'clock. That is no problem. But is that necessary? So what is important here is that you take sutures which are equidistant from each other and there is no lot of defect in between. That is our primary aim. Betadine wash, please. So can everybody see there is no tension at all? Okay. The bulb is sitting very clearly. Okay. And we are going to put a drain. All traumatic cases, all redo cases, please have a drain so that there is no collection which happens inside. Okay. Trauma will always give you some collection because we are dealing with a lot of fibrous tissue, number one. And number two, we are not doing a, augmentation repair. We are doing a transection. So the transected urethral edges, we are always going to ooze out till they heal. So there is always going to be some connection whenever you do a end-to-end urethroplasty. Oh. Sorry. I do not give immediately post-op, but yes, of course, I give 5 milligrams of tadalafil after taking out the catheter actually. Immediately, I don't think so you should be giving. The loop actually gives the problem. This catheter after 3 weeks, yes. Cut. We have no, I will put that there. We have found no advantage keeping the catheter. Like after VIU, now everybody has come to the conclusion that a post VIU maximum what you can put a catheter is for how many days? 72 hours. Okay. So 72 hours is the maximum time you should you keep a urethral folio after a VIU. Drain ready, please. There was telling the muscle fascia is intact. And when I'm closing, I'm not actually taking the muscle. I'm just taking the fascia over the muscle so that the muscle is not compromised. These are small points. Actually, when you start doing redo cases, then you understand that when you open the muscle for the second time and you find that there's no muscle which exists, it is very depressing for the surgeon that the patient has not only lost the urethra, but also lost the muscle, which is very unfortunate. So be very careful in reconstructing these muscles also, because they play an important role. And whenever you do the next surgery, if you find this muscle very intact, that means you have done a good surgery. So in most of the redo cases, what we have found out, there is no muscle which is there. It is completely lost because of ischemia, maybe infection. So drain, please. Be careful. So the drain goes now. इसको निकाल दे अभी, इसको काम होगा. Hold this. So the drain goes superficially, comes out from here. Chalo. Cut. Scissor. Switch a cutting scissor. To cut this drain. Open it up. Force it. नसी को क्लोज करें. ऊपर उठाओ. Sumit will close, no problem. Sumit, खींच लो इसको बाहर. Done. Okay. Finish the remaining closure. Come na government. So next patient is ready. Take कोणाला घेतलं अनिल? Huh? Okay, the other patient is a redo urethroplasty. He had an injury with ball on this genital area, football or a cricket ball, and that time he had some swelling in the scrotum. That's what the history he gives. Actually, does not give any history of any urethral trauma at that time. But what was done that time was important, and end-to-end urethroplasty was done for that stricture. So now when end-to-end urethroplasty has already been done, you cannot actually do an augmentation on that end-to-end because it is like external trauma. What it does, surgery also does. A transecting urethroplasty also does the same trauma to the urethra. That is, nikal na, nikal. It transects the urethra completely from outside. Okay, so there is a circumferential transection. See, what is the difference between a traumatic stricture and a non-traumatic stricture? In a traumatic stricture, there is a circumferential spongiofibrosis. The spongiofibrosis extends from the mucosa up to the serosa. Okay, and that's the reason why the longitudinal blood vessels get compromised and you have to transect to have continuity. In a non-traumatic stricture, there is a spongiofibrosis only submucosal level and the spongiosa around is normal. And that forms the principle of no transection in non-trauma and transection only in traumatic cases. Is everybody clear with that? Even if you go with this message home, we are good. That means we have achieved a lot. So, trauma, non-trauma, no transection. T, T, NT, NT. Okay? Cut. That's good enough. Better in wash than a bit. Samit, can you close? Yeah. Come. So simple monocle sutures, okay? Thank you.